Management of peroperative radialization or a radial tear in a circular capsularrhexis is certainly no joy to behold. It can happen in a wide array of surgical situations. A rock-hard, hypermature cataract, even with a fully satisfactory round CCC, or a case with a well-dilated pupil and a normal nuclear sclerosis +3, where we certainly do not anticipate an extension of a complete capsularrhexis, or even in the case of an advanced cataract with a medium-sized pupil, with the satisfaction of having performed a normal capsularrhexis. The video will take us through 3 such cases. The first case shows a routine phacoemulsification in progress, taking care of the edge of the capsularrhexis. A stop-chop technique is initiated with careful quadrant removal and removing the wedges of thick, hard, leathery cataract. Under controlled parameters, working in the center of the pupil at the level of the pupillary plane. Surprisingly, during the course of removing the wedges of cataract, there is radialization of the capsularrhexis extending peripherally beyond the pupillary margin. Care is taken to avoid that area and to make sure that the last fragment is removed carefully. In the second case, even in the course of a routine phacoemulsification with a very well dilated pupil and a good red reflex during the course of the last stage of phaco, there is a realization that there is an extension of the capsularrhexis inferiorly. The third case is a moderately difficult cataract scenario with an average dilated pupil and a fairly advanced cataract. The capsularrhexis is completed in a perfectly round, curvilinear way under trypan blue, and a routine phacoemulsification is initiated with a stop-chop technique. A deep groove is made, a crack is completed, several wedges are made in the fairly advanced cataract with the second instrument. However, during the course of quadrant removal, as the wedges are brought up in the level of the pupillary plane, it is realized that there's an extension of the capsularrhexis again inferiorly at the 6 o'clock position. As a golden rule, removal of the phacoprobe immediately is an absolute contraindication. One must immediately inject OVD into the area of the radial tear so as to prevent extension or involvement of the posterior capsule or even extension to the periphery before removing the phacoprobe. Irrigation aspiration is initiated, leaving the soft lens matter in the area of the radial tear for the very last, as this tends to provide a cushion preventing further extension to the periphery. careful irrigation aspiration can be done either by the coaxial method or, if in a difficult case scenario, especially with a small pupil and large copious amounts of soft lens matter, one can always do an irrigation aspiration with the bimanual technique. After irrigation aspiration, one has to deepen the anterior chamber with OVD in the area of the tear once again. Careful, slow, controlled implantation of the intraocular lens is always possible, be it a multi-piece or a single-piece lens, avoiding the area of the tear. Carefully dialing the haptics in a position which is 90 degrees to the area of the tear. The implantation and the unfolding of the intraocular lens must be slow and controlled, and one should perhaps not do a wound-assisted delivery and go into the anterior chamber, place the bevel down and implant the lens very carefully. Careful irrigation aspiration of all the OVD in front of the lens in the anterior chamber has to be removed. If there is a large amount of OVD behind the intraocular lens, one can use a bimanual technique. One should try and avoid a toric or a multifocal lens in these cases, as the long-term effective lens position is always questionable. Deepen the anterior chamber with pilocar, make sure that the pupil has come down and the anterior chamber should be deep. The wound integrity and the closure of the wound is very important. The intraocular lens is tapped down after removal of the OVD. This will ensure a deep anterior chamber, a stable intraocular lens, and a happy patient post-operatively.